Hi everyone, today we're going to talk about heart failure for the sub-intern. We're going to go over the basic diagnostic, testing, and treatment of heart failure that you will see on the inpatient wards. One of the first things to remember, even in not heart failure diagnoses, is to avoid an anchoring or confirmation bias. If you're a sub-intern and you are told that you have a patient coming in with heart failure, think about other alternative diagnoses. Think about a patient coming in more with shortness of breath. The role of the ED is to really stabilize and triage a patient, where the role of the internist is really to think and collect other data points. So just because a patient is told that, or you're told that a patient is coming in with heart failure, that doesn't mean that the ED is wrong. It doesn't mean that they did something incorrect, but it does mean that you should consider other options just to make sure. They're really just saying that the patient needs to be hospitalized. Another important distinction in heart failure is that congestive heart failure is a chronic disease. But when symptoms present and a person comes to the emergency room, that is what we call acute decompensated heart failure. And these are where they come in with shortness of breath and different symptoms. There is a wonderful JAMA article that every sub-intern and intern should read called "Does This Dyspneic Patient in the ED Have Heart Failure?" where it looks at what was called a rational clinical exam, looking at likelihood ratios that we'll talk about in a little bit, of determining if a patient truly does have the diagnosis of heart failure. The most important thing when you're seeing a new patient that has heart failure or that you're told has heart failure is to be able to triage and say, is this patient safe and where should they go? The two major criteria for triaging a patient with heart failure is perfusion and congestion. So what we call is usually with perfusion is either warm versus cold. A warm patient has good perfusion. That is me and you, someone who fingertips are warm, seems to have good perfusion. Cold, meanwhile, they might have cold extremities. They might not be perfusing their kidneys, so they're having low urine output. They might not be perfusing their head, so they're having altered mental status. These patients are far more worrisome. Similarly, with congestion, we call them dry or wet. Wet meaning that there's a lot of fluid buildup in the body. So a patient that is wet or with congestion will have a distended jugular vein. They'll have edema. They'll have crackles on exam. They might have symptoms of shortness of breath or difficulty lying down flat. Whereas if they're dry, they're not so much having congestion and may not have so much symptoms. When you look at the chart here, there's a common 4-box table that we use a lot, where if a patient is warm, having good perfusion, and dry without symptoms of congestion, these are the patients we manage chronically as an outpatient. Next, if they are warm and wet, meaning they're good perfusion but having some shortness of breath, some symptoms, these are the ones that you're going to see on the inpatient wards. Anytime a patient has cold perfusion, they almost always need intensive level care, possible pressure support. And a patient that is cold and wet is usually pretty worrisome, and these are kind of the more of the bad news bears patients. When you're presenting or doing an H&P on a patient with heart failure, you have to know what symptoms to look for. In heart failure, patients present with shortness of breath, dyspnea on exertion, shortness of breath when lying flat or orthopnea, paroxysmal nocturnal dyspnea, or waking up in the middle of the night acutely short of breath. They'll often have dependent peripheral edema, so they'll have a lot of swelling in their feet and legs. They'll also have weight gain just from extra fluid on. One of the biggest things that I think makes taking a history a lot easier for these patients with chronic heart failure with lots of exacerbations, just ask them, do you feel like you have extra fluid on you? Do you feel like this is similar to other heart failure exacerbations? This can actually be really helpful, and a good history should not be undervalued. Now, acute decompensated heart failure also usually has some type of trigger that kind of tips the person over. Now, it might be that they're not taking their medications or they're not eating the correct diet. Maybe they have a viral upper respiratory infection or some type of arrhythmia from other heart disease. Maybe they have worsening kidney disease. But there is usually a trigger that causes this patient to be hospitalized, and it's important to try to find this to see what's been going on leading up to the hospitalization. We classify heart failure with really two different classification systems. One is the American College of Cardiologists and American Heart Association staging, A, B, C, and D, where really the stage B is people that have heart disease but no real symptoms. Stage C is patients with symptoms in the heart disease, and D is really bad news bears heart failure. The NYHA functional class, A1 is asymptomatic, 2 with symptoms with moderate exertion, 3 with very minimal exertion, and 4 is symptomatic at rest. Highlighted in red are the stage C and functional class 2 and 3, which these are really the patients that you're going to be dealing with the most of the time. The stage D and functional class 4 are often in a cardiac care unit or working towards hospice essentially. But in stage C and functional class 2 and 3, there's a lot we can do to try to get them in a good place. Whereas A and 1 are usually trying to do more preventive care. When you ask about the past medical history, it's important to do a really good chart biopsy, see if the patient has a history of congestive heart failure, look at previous visits or hospitalizations, and see if this is similar to other presentations and how they were treated. If this is a new sign of congestive heart failure, should also be looking for other issues that might cause heart failure. So ask if they have risk factors. Do they have high blood pressure? Have they had a heart attack in the past? These are often the things most commonly leading to heart failure. Now, if a patient comes in with this shortness of breath, edema, crackles on exam, and really does have new onset heart failure without the known risk factors of hypertension or ischemia, it does deserve a workup. Now, a lot of this can be done outpatient, but there's an appendage slide near the end. There is a broad differential for new onset cardiomyopathy, and there's a lot of zebras that should at least be considered when figuring out why this person's coming into the hospital. There's a few findings on the physical exam that are consistent with acute decompensated heart failure. Things like crackles or rails on lung exam, an S3 heart sound, jugular venous distension, and lower extremity edema are some of the more common things we look for. The table on the right looks at the likelihood ratios when these physical exam findings are present versus when they're not. And you can use a table that essentially helps you determine how much effect it'll have on your pretest probability. But a general sense is that the high likelihood ratio, such as greater than 10 for an S3, is very significant to point you in the direction that this is someone in heart failure. Whereas a lower likelihood ratio of 2.5 with lower extremity edema makes you think that it is still more likely this person is coming in with heart failure, but less convincing as some of the other physical exams. Similarly, with negative likelihood ratios, if these physical exam findings are not present, it slightly points you to think that this is not necessarily acute decompensated heart failure, or at least less likely. Now, there are some different labs that are important to look at for patients with heart failure. One that is kind of the most fun, I think, or that people talk about a lot is this proBNP. ProBNP is kind of like the D-dimer of heart failure. And then if you have a low proBNP, you can rule out heart failure, just as a low D-dimer can rule out pulmonary embolism. If a patient comes in and they have a very low proBNP, you should definitely be considering another diagnosis. If they have a mildly elevated proBNP, it's much less helpful. Next, in looking for a BNP and looking at the electrolytes, a few things to keep an eye out for. Low sodium in heart failure, that's bad. That usually is a sign of kind of later stage heart failure. Also, patients that have heart failure are often on medications that will change the electrolytes. So patients on ACE inhibitors are at risk for hyperkalemia, whereas patients on Lasix or furosemide are at higher risk for hypokalemia or hypomagnesemia. We should also always be checking their creatinine. A lot of these patients will have an acute kidney injury, and this is usually a sign of cardiorenal congestion if they're just coming in. If they have a lot of buildup, they're having trouble truly perfusing their kidneys, they're going to have an elevated creatinine. Now, it is important to note that in a patient that is currently hospitalized, an elevated creatinine is also very common if we are over-diuresing a patient and making them have fluid shifts too quickly or drying them out. So we try to balance this in a way that makes sure that they are getting that fluid that they're coming in with, getting it off without messing up the perfusion to the kidneys. Similarly, if they have a transaminitis or elevated liver enzymes, this can be a concern for congestion causing liver damage. And then a slight elevation in troponin is concerned for what's called a type 2 stress end-STEMI, or essentially a hypoperfusion to the heart. This is a pretty bad prognostic factor, but something that we do see a lot in patients with acute decompensated heart failure. They are not treated in the same ways that you would come in with someone acutely having an MI, but something to be aware of and to look for sure. Other diagnostic testing, a chest X-ray is often important to get. You can see if a patient is wet, meaning do they have pulmonary edema on the imaging. You can also see signs of cardiomegaly. On an EKG, you'll often find left ventricular hypertrophy or a history of ischemia with Q waves and T wave of inversions. And there are some other more complicated signs, but these are kind of the basic ones to be aware of. An echocardiogram is another diagnostic tool that's really indicated whenever you want to reevaluate for congestive heart failure or newly evaluate for congestive heart failure. The major things that you should know that you're looking for is first looking at the EF, or ejection fraction. If a patient has diastolic dysfunction and symptoms of heart failure, then you can say that they likely have heart failure with preserved ejection fraction. That's an EF greater than 50%. Now, if they have an EF of less than 45%, that's usually called heart failure with reduced ejection fraction, or HFrEF. Anywhere between 45 and 55% is honestly a little bit of a gray zone, but these numbers generally do coincide with what we have as the definitions for the disease. Other things you can look at on an echo are things for valvular disease, wall motion abnormalities, signs of previous heart attacks, and then other forms of cardiomyopathy. Again, I just want to reiterate that it's always important to remember to rule out other things. So while you're going through the history, the physical, and the labs for working up congestive heart failure, also think about asking about sputum production, history of smoking. Maybe this is a COPD exacerbation. Or was the shortness of breath very acute? Did you calculate a Wells score and find it to be very high? This might be something considering more of a pulmonary embolism. Do they have a current fever and signs of feeling sick? Maybe this is a pneumonia. So it's always important to not just ask the heart failure questions, but also the questions for the other diagnoses that present with similar shortness of breath or other symptoms. Every sub-I and every intern for every heart failure patient needs to know a few things. One, what is the type of heart failure? Is this HFpEF or HFrEF? And how do you know that? When was the most recent TTE? And what was the date? Second, you need to know the etiology of heart failure. Is this ischemic? Is this amyloidosis? Is this long-standing hypertension? These are important things to know or to try to find out during an inpatient admission. What was the trigger for the exacerbation? Did the patient come in with an upper respiratory infection? Did they have some noncompliance with their medicine or with their diet? Looking for a trigger is an important part of your history. Also, this concept of an estimated dry weight. A lot of patients will know that what their weight is when they have all the extra fluid off and their heart failure is at a good level of control. This is an estimated dry weight, and usually this becomes the discharge goal weight to try to get someone to a level where they do not have extra fluid on. And finally, we cannot undervalue the importance of medication reconciliation. You should know every medicine that the patient's on, what it does, why they're on it, what's the indication, and what the dosing is. The big picture for treatment of heart failure is really just diuresis. The goal is to have a net negative I&O, meaning have them pee off more fluid than they have than they take in. The way we do this is using a medicine often called Lasix or a loop diuretic. We use IV Lasix. This encourages this acts on the kidney to increase urine output. We use IV because the oral version is thought to have poor absorption if there is so much edema that you also have intestinal edema. And the outpatient, though, patients will take Lasix as PO. I bolded the 6 in Lasix because that is the half-life of the medication. If you give a dose of Lasix, you can count it to be in the system for about 6 hours. A way to figure out how to dose it, the easiest cheat is just to look for previous dosing. If they're on Lasix at home, you can start with double the patient's home oral dose, but IV Lasix is twice as potent as PO, and therefore you would actually start with the same IV dosage as their PO dosage. We also have these patients on a low salt diet and a water restriction, less than 2 liters. This again tries to decrease the amount of fluid that they retain. And then we replete electrolytes. And there are some that do these high goal electrolytes, meaning your goal potassium is greater than 4, your goal magnesium is greater than 2.4. This is again because the medicines that we're giving decrease potassium, decrease magnesium, and lower levels of potassium and magnesium can cause arrhythmias. That being said, there's really not a lot of great evidence for maintaining high goal lights. Next question is, when can we discharge these patients? And there's a few criteria that are important, and these are what we're working on a day-to-day basis to try to get the patients better so that they can go home. First is they cannot have an oxygen requirement. Maybe that's obvious. 2 is that their symptoms have improved. They're not having shortness of breath. 3, their edema or whatever they came in with is improved or at least back to baseline. 4, again, this concept of a dry weight is achieved. And physical therapy and occupational therapy is also an important interdisciplinary team player in heart failure treatment. And we want to make sure that they can safely go home and they're safely able to walk. The other thing is really finding the optimal medical treatment to make sure they're on the right medicines for treatment of their heart failure, but also for their comorbidities, for their hypertension, for their coronary artery disease, for their diabetes, and other preventative medicines to make sure that we're keeping their heart in good health. This is a table that can be a little overwhelming, but looks at the medical optimization for patients with heart failure specifically. Now, again, we also want to treat their diabetes, their hypertension, but there are indications of medicines for patients with heart failure. The majority of this chart applies to patients with heart failure with reduced ejection fraction, but this is to make sure that they are being medically managed in an appropriate way. The patient should be on a beta blocker, specifically carvedilol or metoprolol succinate. They should be on an ACE inhibitor or a angiotensin receptor blocker, or one of these new medicines like Entresto, which is sacubitril and valsartan, which is shown to prevent mortality in heart failure with reduced ejection fraction. This Entresto is a very new medicine, a new trial paradigm HF, which has really gotten a lot of press in the past year or two. An aldosterone antagonist like spironolactone is also a routine medicine. This chart says when they're indicated, and for the ones in green, this is basically anyone with symptomatic heart failure. There's some trials that you'll notice are often probably cited on rounds, and then the RRR, or relative risk reduction, to show what the decrease in mortality or cardiovascular outcomes can be with these medicines. And you'll notice they are pretty significant, so they're pretty strong. For patients that have a very low EF or an EF of less than 35%, other indications, there's indications for other treatments. One is for ISDN, a nitrite with hydralazine. This is specifically in African Americans or a black population, shown to decrease mortality pretty impressively. Also, anyone with an EF of less than 35% should be evaluated to have a defibrillator placed, or an ICD. And if they have an EF of less than 35% with arrhythmias that are causing a long QRS, a left bundle branch block, they're actually indicated for CRT, or essentially a pacemaker, or cardio resynchronization therapy. And then, of course, all this with the Lasits to try to take all the fluid off. These are the major points in diagnosing and what to look for in a patient coming in with heart failure, and then the basic big picture treatment. If you have any feedback about this lecture or how a video like this should be better, or what was good, what was bad, please shoot me an email at jberk7@jhmi. It's possible that there will be other videos like this in the future. If this was helpful, please let me know. If it wasn't, please let me know. If there are certain things that were good, certain things that were bad, we can make it so that other videos are more helpful. There's a few appendix slides that also have some other likelihood ratios and other things that might be helpful to look at as far as guidelines for treatment. Thank you. The following slides are some appendix slides that might be good references in learning about congestive heart failure.